Welcome to episode 41. I actually thought it was episode 50 for some reason, but we're only up to 41. I will celebrate when it's number 50. And the topic today was actually a question that was asked many weeks ago. So this was a question on the effect of obesity on volatile washout. But to get to this stage, we had to go through the last couple of weeks and going through the ideas of how cardiac output affected volatile washout. And from there, we can actually apply some of those concepts today because they are relevant in terms of how we answer this question. Now, as always, with the breakdown of the short answer question, we'll review the exams report. And then after that, we'll do a literature review and I'll present you the key concepts. We'll go through any questions that you guys have and I'll show you an answer structure and then we'll all write an answer to time. So this is the question from 2019. Describe how morbid obesity might affect washout after inhalational anesthesia. And the exams report, so I've highlighted all the important things that we need to add into our answer. The main domains assessed in this question were definition of morbid obesity, pharmacokinetics associated with morbid obesity, effect of specific inhalational agent solubility on washout, the inhalational washout curve, effect of anesthetic duration, respiratory problems of morbid obesity during recovery affecting washout. There's quite a lot there to unpack. And I think the challenge is including all these domains into our 10-minute answer. Now, credit was given for other relevant correct material, such as context-sensitive recovery from inhalational anesthesia, tissue equilibration times, decrement times of inhalational agents, and the effect of controlled ventilation by the anesthetist during emergence. Now, Bwen, do you know what the difference is between context-sensitive recovery and decrement time of inhalational agents?
So decrement time, it's just like the time that how many percent of that volatile concentration decrease over time.
Yeah, exactly.
And yeah, so it can be 50%, which is like a context and half time. It can be 90%.
Yes. And in actual fact, they're very similar things because, as you said correctly, when you talk about like the context sensitive halftime, the decrement time there is 50%, but you'll see other times being used, such as the decrement time for 80% or decrement time for 90% of inhalational agents to wash out. But a lot of it is also based on time. So I think that, the idea of context sensitive recovery and decrement time are very analogous. And I think what is confusing is that when you read it in this context here, because they're separated by this idea of tissue equilibration time, you think they're different concepts, but they're actually very, very similar concepts, as you correctly described. Highlighted in red is concepts that we need to make sure that we get right or avoid putting in. So common problems were poor knowledge of respiratory changes of morbid obesity in the awake state and upon emergence of anesthesia. Misconception about the effect of cardiac output on inhalational washout, and washout curves with wrongly labeled y-axes. Cristy, what do you think the misconception is?
I'm wondering if perhaps it was like not correctly doing FA-FO.
Correct.
Some people, I think by default, you go for FA-FI.
Yes.
Or they just, like I've just seen that sometimes that can be confusing for people and whether they need to explain it as well.
Yeah, that's spot on. So what would have, I think what would have occurred is that on the y-axis, they would have labeled it as a wash-in curve, which is your FA-FI curves, rather than as a washout curve, which is your FA over FAO. All right. Now, the last thing is better answers incorporated the effect of morbid obesity and specific inhalational agents into the washout curve. Now, I've just created a summary of the exams report here. So we need to make sure that we have a definition of morbid obesity in our answer. Then after that, we need to discuss some of the pharmacokinetic changes associated with morbid obesity that's relevant for volatile anesthetics. We need to include a washout curve. And on that washout curve, we can have concepts such as the differences between different volatile agents. And I think the most common one to draw would be ISO versus DARES. You can also include other ideas such as the effect of anesthetic duration with the concept of tissue equilibration times. Most commonly would be muscle versus fat, or even, and if you can even remember the vessel-rich group as well. Then after that, talk about the context-sensitive recovery and its relevant decrement times. And then finally, we need to talk about the effect of minute ventilation, and somewhere in there, talk about the impact of spontaneous ventilation versus controlled. Now, because this is such an applied physiology and pharmacology question, what I've done is I've done a lit search and I found a couple of articles related to morbid obesity and specifically washout of volatile agents, especially in morbid obesity. The methodology to answer these applied questions is really to ask yourself the basic premise of one of the key concepts. And here, the key concept is what affects washout. Now, Faser, if you got asked this question, what would you say in terms of what are the factors that you think are important that affects washout of volatile agents?
So I guess you'd start with talking about the different phases of washout, and talk about the kind of the volatile agent leaving the alveoli circuit first of all. So that relates to your fresh gas flow, correct, as well as your minute of ventilation. And then subsequently talk about the redistribution phase. And so the relationship of the duration of the anesthetic and how much anesthetic was delivered during the anesthetic case, and then talking about the relative saturations of your compartments. Good. And then the factors that influence that.
What are some of the other key factors where morbid obesity can impact?
So I suppose the other factor is that they have larger muscle and fat compartments.
Yes.
I suppose in clinical practice, the larger muscle group is going to be probably more clinically relevant.
Yes.
In terms of that one having a faster equilibration time than fat, just because of the relative proportion of cardiac output. And therefore, there's just going to be more volatile anesthetic that's going to have saturated that compartment. And therefore, yes, it will take longer for that to go into your blood and then subsequently be exhaled out through your alveolus.
Great. And anything else? So you've got minute ventilation, you've got size of the compartments.
They've got more cardiac output, but I can't really.
Yeah. So cardiac output is going to be another factor that's going to affect washout. And as you said, in terms of the saturation or the amount of volatile in the compartment, that's going to be based on how much you've delivered and also the time as well. Okay, well done. There is one other small one that's there, but I'll go it through with you in the next slide. Now, to think about washout, we can refer to this diagram here. And in this diagram here, we've got the lung where it interacts with the circuit, And then after that, it distributes itself to the muscle, fat, and vessel-rich group. And at the end of anesthesia, those compartments will redistribute back the volatile agent back into the lung, where it is then cleared from the circuit. And if I was to highlight this diagram in terms of the factors, you can see all those ideas which Faser talked about. So starting with 1, you've got the idea of the compartment sizes, as well as the amount of uptake there are in the vessel-rich group, in the muscle, and in the fat. And then secondly, you've got this idea of redistribution, and that is going to be impacted by your cardiac output. So that the higher the cardiac output is, the more volatile agent that's going to be redistributed back from the vessel-rich group back into the lung. And then after that, from the muscle into the lung, less so from the fat, because the fat is kinetically slow. And quite often the concentration or the partial pressure in the fat, the gradient doesn't exist just as yet. So in other words, probably in the first, I would say, 15, 20 minutes, there's actually distribution from the lung to the fat, rather than redistribution from the fat to the lung. But it's such a kinetically slow compartment that we can often ignore it with regards to the kinetics of washout, because these ideas happen very, very quickly, okay? Now, from the lung, you've got the third concept, which is minute ventilation. And then after that, you've got the factors that affect the circuit, and primarily that's going to be your fresh gas flow. Now, the fifth concept I've put in here, which is the other way that volatiles can be eliminated, is through metabolism or hepatic metabolism. So it's less so for the more modern anesthetic agents such as desflurane and sevoflurane, but more relevant for things like halothane. Cristy, what would you say about how does morbid obesity affect some of these factors?
Okay, so I think firstly, like we sort of mentioned, morbid obesity, you have an increase in your body mass,
yes,
which increases your overall cardiac output. And then, so because of that, you have increased alveolar ventilation.
Yes.
And I guess you're going to have, like you talked about, the redistribution from those different groups, your muscle and vessel rich, I think will be higher because of the increased cardiac output.
Yep. When we think about morbid obesity and how it affects these factors, Cristy, you're right. So that there's going to be a larger mass in terms of the vessel-rich group, muscle group, and a lot more in terms of the fat. I've got 2/3 in terms of fat, and then 1/3 in terms of muscle and vessel-rich group, in terms of the overall contribution of how much morbid obesity affects those compartments.
Okay.
And when we sort of answer that question of how does morbid obesity affect those factors, we can actually create a basic structure that we can apply to answer this question here. So that we can say that morbid obesity is going to be affecting the size of the compartments, specifically the vessel-rich group, the muscle group, and the fat group. It's going to be affecting cardiac output, affecting minute ventilation. You can even make mention that it affects hepatic metabolism. It is an inducer of hepatic enzymes. And then there are independent factors. So things that we can control as anesthetists, understanding, the patients that we have. And those would include the choice of volatile agent, the fresh gas flow, as well as the concentration dialed. Now, this is a review also of some of the concepts that we covered previously in the last couple of weeks. And that has to do with the uptake of volatiles into the compartments, so the vessel-rich group, the muscle, and the fat. And all those ideas are a function of the choice of volatile agent and that's based on the tissue blood partition coefficient, the delivery to tissues per unit time. So those are based on circuit factors and patient factors. So circuit factors would be concentration dialed and your fresh gas flow. So this is during the washing phase. And then patient factors, or in fact, they can even be anesthetic factors because you can control the minute ventilation. So these are things like cardiac output, and then the size as well of those compartments. So the vessel-rich group, muscle, and fat. And then finally, there's going to be that idea of time. And the idea is that the longer the anesthetics, the more that you're going to take up in terms of tissues per unit time. And that's where that idea of context-sensitive half or decrement times come in. Bwen, what is the common assumption of how morbid obesity slows washout?
I guess it's probably two reasons. First is because they have increase in their muscle as well as fat body compartment. So
Yes.
you saturated the compartment. And I think the second reason is cardiac output. So you have higher cardiac output in obesity, and because you saturated those compartments, you get more redistribution from these compartments than your vessel-rich group, a higher proportion of it.
Yep, spot on. So I think that the most common reason, and the thing is, you guys are actually way ahead of the curve because you guys actually know that muscle is another important, in fact, the more important group here. But the most common, I think, assumption or explanation is that it's because of the fat. The increased fat is the reason why patients with morbid obesity have a slower offset or slower washout. And we've got a study here from Cristy, which shows the washout of sevoflurane in obese versus non-obese patients. So the curve in the triangles, this one down below, is non-obese, and then the curve that is circles, they are the obese patients, and the volatile agent here is sevoflurane. And you can see that the non-obese patients have a quicker washout than the obese patients. Now, Faser, do you want to comment anything about this curve? Things that you notice, things that you see different?
Do you mean compared to the ones that we typically use?
Yeah, compared to the ones that you've seen, correct.
So I'm used to the y-axis being logarithmic. So in terms of, it seems to just be in 0.2 increments, and the time frame is extremely short.
Yes. When we see the curves that are represented in our sort of core textbooks, you'll see that the FAO curve is a log curve, and so that the numbers that you'll see range from 0.001 all the way up to 1. And then the minutes of elimination often head up to about 2 hours. Now, the common explanation, as I said before, and I've just highlighted it in this passage here, is that it may be speculated that the increased amount of sevoflurane taken up by fat tissue in the obese patients could delay the washout kinetics compared to non-obese patients by increasing the anesthetic delivery to the lung from the body tissues after discontinuation. And this could also be partly related to the increase in cardiac output induced by obesity. And I think that this idea that the fat compartment contributes to delay in washout is one that's, I guess, perpetuated and it's a very, very common idea and misconception. But we know that that is not true because of how kinetically slow the fat compartment is. So I've got another passage from an article by Eager, which says that Obesity increases the depots available for storage of anesthetic, including anesthetic that reaches fat by intertissue diffusion. Such anesthetic returns to the circulation to delay recovery in healthy and obese patients, particularly with more soluble anesthetics. However, the increased anesthetic in fat occurs at a lower partial pressure and thus might not influence emergence materially. And what does he mean by that? Is that, yes, there is increased storage in obese patients, but if you actually look at the concentration in the fat compartments, the concentration of partial pressure, it's actually less than MAC or wake. In other words, it is going to contribute more in terms of the redistribution back to the vessel-rich group and to the lung. But because it occurs at a much lower partial pressure, more importantly, below MAC or wake, it shouldn't contribute to the re-anesthetization or rehypnotization or even the delay of wake up of patients. And I'll show you that through some of the simulations through GasMan. Now, the reason for this, and I think we all know this, so this is the table from Igor as well, is because the fat group is kinetically slow. And the time constants here is that fat has a time constant of 1,350 minutes for desflurane and 2,110 minutes for isoflurane. And the time constants for tissues is related to this formula here, so that the time constants is the tissue blood solubility multiplied by the volume of the compartment divided by the cardiac output. Now, how about the vessel-rich group and muscle? So they're a lot more important because they're kinetically a lot faster. And if you look at the time constants for the vessel-rich group, it's about 6 minutes for desflurane and about 9 minutes for isoflurane. And when we talk about the muscle group, it's about 50 minutes for desflurane and 80 minutes for isoflurane. So well within the ranges that we conduct anesthetics. Now, this is the simulation that I've done on GasMan. So this is a wash-in for 1 hour in a 70 kilogram versus 150 kilogram patient. I've just changed the masses. What I haven't done is I haven't changed the cardiac output or the minute ventilation. Obviously, if I did that, it will affect some of the numbers, but the general principle should remain the same. Bwen, what do you think about the differences in the boxes here? So I'll just quickly run through the numbers. In a 70 kilogram patient, your vessel-rich group is 2.57, your muscle group is 0.87, your fat is 0.06. In the 150 kilogram patient, your vessel-rich group is 2.51, your muscle is 0.42, and your fat is 0.02. What do you think about those numbers?
It's actually lower in the 150 kilogram compared to the 30 kilogram.
Yeah, and I think that is one of the interesting observations, is that the concentration in your vessel-rich group, muscle group, and fat group is actually lower than it is in your 70 kilogram patient. So if you look at this other box that I've highlighted here, you look at the uptake. The uptake in a 70 kilogram person is actually less than in a 150 kilogram person. So that idea, I think, makes sense, that there's definitely more uptake in tissues, right, in a patient who's larger, but the concentration is lower in a 150 kilogram patient versus someone who's 70 kilograms. And I hope that realization that it has to do with the size of the compartment. In other words, like if I had like 100 milligrams of a drug and I put it into a liter of water, that's 100 milligrams in a liter. That's my concentration. But if I actually have 120 milligrams of the drug So I've got more drug, but I put it into a 2-liter compartment. The amount of drug I have in the compartment is more, but the concentration is less. So in other words, if I put 120 milligrams in a 2-liter compartment, my concentration is 60 milligrams per mil. Does that make sense? So in other words, the overall amount is more in someone who's morbidly obese, but the concentration is less. Okay. And look, this is for a 1-hour anesthetic. Obviously, the longer the anesthetic, because remember that morbidly obese patients have a longer time constant, the more likely that the compartments are going to equilibrate. Okay. But for an hour anesthetic, what you're going to have is you're going to have a lower partial pressure in those compartments, but overall, there's actually going to be more amount of volatiles in those compartments. And those are the observations here, is that the concentrations in the non-obese compartments is actually more than the concentrations in obese, but the uptake in non-obese is actually less than the uptake in obese. And the other observation that you should make is that the fat compartments only have 0.06 and 0.02. So again, way below MAC awake. And that's why they're not kinetically important with regards to the washout of volatile agents, okay? Because they're way below MAC awake. And so in order of importance, it's going to be your vessel-rich group, followed by your muscle, followed by your fat. Now, this is the washout. So the washout has taken approximately about 11 minutes for my vessel-rich group to reach less than MAC awake. And Bwen, what are your observations here?
Yep. So in a 70 kilogram, you can see that in your alveoli is less than MAC awake, and the vessel-rich group is approaching. I mean, it's kind of less than MAC awake, but in 150 kilograms, even though your lungs has MAC awake of 0.46, but your vessel-rich group is still at 1.
That's right.
There's a delay.
Correct. And look, the other really interesting thing is that if you look at the muscle group, so the muscle group in your 70 kilogram patient is still above MAC awake, all right? But you look at your 150 kilogram patient, it's less than MAC awake. And this is why it's so complex. But one of the problems that can occur is that if this 70 kilogram patient, for whatever reason, developed hypoventilation in recovery, that muscle group has the potential to re-anesthetize the patient because it's above MAC awake. Versus this 150 kilogram patient, let's say hypothetically you've washed out everything in the vessel-rich group, because that muscle group is less than MAC awake, it shouldn't contribute to re-anesthetization of the patient. Now, the caveat being that if you had an anesthetic that was much, much longer, so, let's say 3-4 hours, then you would see the muscle group in that morbidly obese patients increase above MAC awake, and that's when you get the potential for re-anesthetization, okay, in recovery. And so these are the observations. The observations are that washout. So when I talk about washout, I'm really specifically focusing on what's happening in the alveolar. So washout in non-obese is faster than obese patients, okay? And then when I talk about offset, offset really is talking about what's happening in the brain, which is related to the partial pressure in the vessel-rich group. And again, the offset in non-obese patients is faster than obese patients. And here in a 70 kilogram patient, it happened about 11 minutes. I haven't shown you here, but the time it took for the vessel-rich group to cross MAC awake was about 16 minutes. And that's pretty much what we see clinically. We see that difference of about five or so minutes for a morbidly obese patient to wake up compared to a non-obese patient. And then the third observation that I think is really interesting is that, the muscle concentration in obese patients is less than MAC awake, all right, for a 1 hour case. And as I said before, if the case was a lot longer, then you would see that concentration become higher. And I've just superimposed those two curves to sort of show you what they look like. So this curve is not a FA over FAO curve versus time. It's just an FA versus time curve. All right, but you can see what the general shape looks like in terms of the differences. So they both show a multi-exponential decay process. And the top one is the obese patient, and the bottom one is your non-obese patient. And I think we can draw the conclusion that, yes, obesity does slow washout, and it does that because of increased storage or increased uptake in your vessel-rich group and muscle. And from those simulations, we know that fat is less important. Now, does choice of volatile agent matter? Fraser, what are your thoughts on that?
I would have said that it does, with increasing lipid solubility. Presumably, they're also going to have, therefore, a greater affinity for the tissues. And so you're going to get, with a larger compartment that patients with obesity have, you're simply going to get even more accumulation of that volatile anesthetic agent. Correct.
This is what the studies have shown. Several studies in obese patients have compared some kinetic aspects for inhaled anesthetics with variable results, perhaps because of different experimental conditions. For example, Strum, DeBatamaker, and LaColla showed that morbidly obese patients emerge from anesthesia more rapidly after desflurane than after sevoflurane anesthesia. However, Arain and Vallejo did not find a difference in time to awakening between patients receiving desflurane or sevoflurane. Finally, sevoflurane seems to provide a slightly more rapid washing and washout of anesthetics in morbidly obese patients than does desflurane. So look, I think we can say with confidence that in terms of choice of volatile agents, there's definitely going to be a difference between ISO and DES, and even ISO and SIVO for morbidly obese patients. I think that one there we can say with confidence that there is going to be a statistical difference because of all those reasons that you explained with regards to its lipid solubility, that isoflurane in morbidly obese patients will lead to a slower washout than both SIVO and DES. Now, I've just shown you a table here of DES versus ISO, and you can see that the time to response to verbal command, there is a significant difference, 420 seconds versus 246. And as I said before, I think you can say with confidence there is going to be a difference between ISO and DES. When we talk about SIVO and DES, I think probably less so. All right. Now I've got another study here which shows sevoflurane versus isoflurane. And again, you can see that sevoflurane is shown by the triangles and isoflurane is shown by the circled dots, and that sevoflurane washes out in morbidly obese patients faster than isoflurane. And again, observations of this curve compared to the ones that you normally see, minutes of elimination are set at 5 minutes. And this one here is it's an FAO curve. That is not a logarithmic curve. So that's just from 0 to 1. And then I've got another one here that shows desflurane versus sevoflurane. And as I said before, you can see that, yes, there is that trend that desflurane has a faster washout than sevoflurane. But why do you think it's hard sometimes for some studies to show a statistical difference between the two, Bwen? What are your thoughts on that?
Is it because the difference is really small?
Yeah, correct.
It's like
absolutely
half a minute difference, which is.
Yeah, so in this study here, because you're dealing with such small numbers, the variability, and we know that there's so many other factors other than just volatile anesthetics that can affect time to wash out. And because of that variability, that's why sometimes it can be hard to sort of show a difference that's significant between sevoflurane and desflurane. And it really depends, as that previous paragraph discussed, it really depends on the type of study. Now, Cristy, can you make a comment on this curve here versus the other curves that I've sort of shown you with regards to washout? What do you think about the shape of this curve versus the other shapes that I've shown you?
So this shape, I guess, is more like the curves we're used to seeing for washout.
Yeah.
The minutes with the sort of rapid redistribution and then the elimination. I mean, it's still only 5 minutes, which isn't that long on the x-axis.
Yes.
And I guess the difference, because we're just comparing volatiles, isn't that great compared to some of the other, compared to like just morbid obesity versus the normal population. Yes,
yes. And I think if I can show you sort of the previous graph here, you're right. So the previous graph, you certainly don't see that multi-exponential decay process in that 5-minute time frame in those other curves that I've shown you, but you certainly see it here, don't you? You certainly see this multi-exponential decay, and it happens over 5 minutes. You look how quickly it reaches the a ratio of 0.3. It reaches it, even with sevoflurane, it reaches it within a minute.
Yeah.
Whereas you look at this other one, it's taken about maybe 2.5 minutes to reach a ratio of 0.3.
Is it just the duration of the anesthetic?
Yeah, you're on the right track. So yes, it could be the duration. And when we talk about duration, which one would be shorter, which one would be longer?
So like this one we're looking at right now would be shorter.
Correct.
And the one would be longer.
Yes. Yeah. And then what would be another reason why? So yes, it could be a shorter anesthetic.
Well, one of the factors I would have thought would be perhaps the concentration, but both of them are at 1. I think I didn't actually pay attention on the other graph.
That's right. Correct. You're spot on, Cristy, and I'll show you the table here. So one of the key things about this study that was done was that look at the gas concentration at where washout occurred. So in other words, when they stopped the anesthetic, in other words, they were running a MAC of around 0.6, 0.7 before they switched off the volatiles. What you can sort of appreciate with that is that the amount of volatiles in tissue is going to affect your washout. In other words, that if you run lower MACs, your washout is going to be quicker, okay? And the differences between desflurane and sevoflurane. So yes, in this study, it was significant, statistically significant, but in terms of clinically, whether it's significant or not, you're only looking at a couple of minutes, and you would even argue that maybe it's not even clinically significant at all. And I think that's one of the techniques that a lot of anesthetists are using nowadays when they do choose to utilize sevoflurane, is that they will run lower MACs, and instead they will supplement it with things like remifentanil. And you can see this study here used remifentanil, which is why you can run lower MACs. And that way you can actually achieve a much faster washout in morbidly obese patients. So instead of running them at, above 1 MAC, you run them at lower MACs, but the way that you do it and the way that you understand how you can lower your MAC is to use adjuncts. And the most common adjunct here is remifentanil. Now, Cristy, I want to discuss an idea. I think that a lot of times when we discuss this multi-exponential curve, we often say this drop is due to redistribution, and then this other one is due to elimination. Now, when you say redistribution, what do you mean by that?
So redistribution is maybe not the best term, but I think like that's more your rapid washout.
Yes.
From your circuit.
Correct.
And the FRC. So that's sort of what is in there. And then you actually start to you enter the slower washout phase, which is where you're having everything that's been redistributed from the other compartments into the blood back into the alveoli.
Correct. Now, I can tell you, and I'll show you another graph where it's misrepresented. We get that idea of that distribution. So that initial drop, which we call the distribution phase, and that elimination phase. Where do we commonly see that?
Do you mean on a different sort of graph?
Yeah. I like, where do you think that idea comes from? Where, you know, we talk about a distribution phase and elimination phase.
I think that sometimes comes from our IV, like,
Yeah, correct. That's right. So with IV anesthetic agents, when you give a bolus, often the offset for most drugs is going to be due to distribution. Okay. And then after that, the second phase of that multi-exponential decay is going to be due to elimination. And that's where those ideas come from. But when we talk about volatile agents, which we run over time, it's not going to be distribution that causes that initial rapid drop in your alveolar concentration. As you said, Cristy, it's due to the kinetics of the washout from the lung with minute ventilation as well as fresh gas flow. And because those are very kinetically rapid processes, that's what causes the large drop. And then after that, the flattening out is due to redistribution back from the vessel-rich group, the muscle, and the fat. And that's what causes the slowing as that redistribution occurs back into the lung. And then after that, it needs to be eliminated via the circuit. And this is exactly what I want to talk about with some comparison of some washout curves. So we've talked about this one here, which is the ones that you'll see in textbooks. And often you can see that the x-axis has the minutes of elimination of up to 120 minutes versus the ones we've seen, which has only been 5-10 minutes. All right. And then after that, the other thing that you'll notice is that this FAO curve is on a logarithmic scale. So 0.01, 0.01, 0.1, and 1. Whereas the ones that you've seen previously have just been on a normal FAO curve. So those are the things that would be the differences. All right. The other concept here is this diagram here, and where it's described as distribution and terminal elimination. And again, I would not use those terms to describe the washout of volatile agents. So I think that, yes, you can apply it for intravenous agents, but understand that distribution does not occur in such a rapid form during the washout of volatile agents. It's due to the kinetics of your minute ventilation and fresh gas flow. And then lastly, sometimes you'll see this diagram here, and it can be a bit confusing. And Faser, what are your thoughts about this diagram?
I'm not sure what FD is.
So that's fraction delivered. So my question is this a wash-in or wash-out curve?
When it lines up with 1, so it would make me think that this is a wash-in, because
Correct.
as the alveolar concentration increases, it will approach 1.
That's right.
Because FA is on the denominator.
Yes. So so this is by the group from EGA, and I think the most common washing curves that we see is normally FA over FI, but they've actually inversed it, and this is what confuses some trainees sometimes when they see this graph, is that it looks like a washout curve, but as you correctly said, it's actually a washing curve, but the comparisons are different. Instead of a FA-FI, this is a FI versus FA curve. And the reason why they've shown this is to sort of show you that if you use higher concentrations versus lower concentrations, what are the differences that you'll see between the two groups. I'll just show you my structure for this answer here. And remember, you can use the other structure that I showed you. And what I mean by that is you can use this structure here, where you can base it on the factors that are relevant for washout of volatile anesthetics and how morbid obesity affects those factors. And that would be a way to structure an answer for this. My way of structuring this answer will be sort of similar, but it's a little bit more nuanced in terms of what are the important components of why morbid obesity slows washout, and then also what are the other things that the other factors that also can compound those differences. And if I was to go through with you my structure, I'd have my definition of morbid obesity. And then after that definition, I will have probably half a page where I'll talk about the slower washout due to the increase in cardiac output. And I'll have a diagram there that should be easy enough to do. And also due to the size of the compartments as well. So cardiac output and size of the compartments. Those are probably the two main things. And then after that, I'll probably add the diagram actually after the size of the compartments, I think. And after that, I will have the washout can be also affected by the choice of volatile agent. And I'll also have a diagram there, duration, ventilation, and I'll also talk about metabolism as well, and try to incorporate all those ideas in the examiner's report. Now, the diagram that I will draw, so I won't draw the log FAO. I'll just draw a FAO curve. And the minutes that I will have will probably be about 30 minutes or 15. I'll probably do 15 to 30 minutes, I think I'll draw. So I certainly won't draw 2 hours on my washout diagram. Got my pen. Oh, I need my ruler. I'm going to draw some diagrams. All right, guys, you ready? So we're going to answer the question, describe how morbid obesity might affect washout after inhalation anesthetics in 10 minutes. And let's go. So first of all, over here, I'm going to start off with a definition. And then after that, below, we're going to talk about washout in morbid obesity is slower because of increased uptake of volatile agents. That's my second concept there. And I'll leave probably 1.5 pages. I'll leave a page for that, and then so I'll also say that washout of volatile agents are affected by. And then the things that I want to talk about is 1, my increase in output, and 2, increase volume of the vessel rich group, muscle parts. And then the things that I should talk about for washout of volatile agents also affected by choice of volatile agents, and I'll have a diagram there. To increase amount delivered to tissues based on fraction inspired, which is my concentration, and as well as increasing duration. And I'll bring in the ideas of context-sensitive half-time there. And then I can probably talk a little bit about routes of exclusion, which will be ventilation, and I'll leave 2 lines for metabolism. Right, so that's my basic structure there. So my definition, so morbid obesity, and O is a BMI more than 40 or more than 35 with comorbidities, excess body weight is due to increase in 2/3 fat mass, which is poorly vascularized, and increase in 1/3 muscle organ mass, highly vascularized. Okay, so increased. So this increased cardiac output to the vessel, which group, muscle, and compartments. Be actually more important than fat because of their respective time constants. So e.g. for DES, VRG is 6 minutes, muscle is approximately 50 minutes, fat is approximately 1,350 minutes, where the time constant tau equals the blood gas solubility minus the volume divided by cardiac output. So when we talk about this increased volume, and the graph that I will show would be the one time FAO 1 0 0.5, and we can say this is approximately 15 minutes, and we'll have one probably washing out at about 5, so crossing 0.3 at about 5 minutes. So this is non-obese, and let's say that this is obese. So choice of volatile agents. So ISO slower than SIRO and DES because of increased solubility. FAO 0 to 1, again time 15 minutes. There's Vivo, and then ISO should be up here. ISO. Increase amount delivered, so increased duration of administration will increase the context sensitive path for decremental times. This means choice of volatile agent affecting washout counts more important with cases, i.e. preference to use DES over ISO. Okay, routes of excretion. So we can say presence of obesity, hypoventilation syndrome can slow washout if spontaneously ventilating mitigated by controlled or assisted ventilation during emergence, and we can also increase BMI, causes basal atelectasis, increasing shunt, decreasing transfer of gas from arterial to alveoli, decreasing washout. And last minute we'll go MO increases metabolism of volatile agents not significant for DES, which is 0.02%, and SIBO, which is 2 to 5%. And the increased metabolism is via enzyme induction and increase hepatic blood flow. That's minimally metabolized. All right, it's my 10-minute answer. Bit rusty after coming back from holidays, but I'll just show it to you. So I've got my definition here, and I've got my overarching statement that washout in morbid obesity is slower because of increased uptake of volatile agents, and that's due to an increase in cardiac output, increasing delivery to agents there, as well as the increased volume of the vessel-rich group muscle and fat compartments, and that leads to a slower washout. And then I've just talked about also that washout of volatile agents is also affected by your choice. ISO slower than SIBO and DES, just got that graph there. And then also the amount delivered, which is based on the fraction inspired of the concentration as well as duration. And then just quickly mention of the context sensitive half or decrement times. And then just the idea that that as you increase the duration of anesthesia, your choice becomes more important. So in other words, preference to use DES over ISO. I maybe should have put preference to use DES or SIBO over ISO, actually. I don't want to be sort of too controversial and just say that DES is what we should use for morbid obesity. I know that there's been a couple of letters into the ANZCA bulletin about that, but there's also that environmental concern. So we'll play it safe here. And then third is the routes of excretion, where I talk about ventilation. So presence of obesity hyperventilation syndrome can slow washout, and that we can mitigate that by controlled or assisted ventilation during emergence. And then just a quick thing about shunt. To alveoli to washout. And then after that, the last thing about metabolism, just a short couple of lines.